Hello everyone, welcome to the September POCUS webinar. I'm Dr. Priyadarshini Marathe, emergency medicine consultant and POCUS lead at the Oxford hospitals. We began the POCUS webinars in April this year to facilitate learning and discussion of point of care ultrasound because we couldn't meet face to face. These meetings, of course, are open to everyone. We would like the POCUS novice, the POCUS enthusiast, and the POCUS expert to come along and join into the fun discussion. Today is our 6th POCUS webinar, and the theme for today is the inferior vena cava. We'll start with a video demonstration of how to obtain a good view of the IVC. This is, of course, part of the triggered assessment for echo and life support and for the AAA scan. We will then discuss the evolution of IVC scanning over the decades. What are the pitfalls? What are the controversies? And when and how to use the IVC in determining fluid status and fluid responsiveness. We'll take questions at the end of the presentations. Please raise your hand using the hand sign or use the chat box to put in your questions or your comments, which we'll take note of and address at the end of the presentation. If you would like to tweet about today's webinar meeting, please use the our handle at HOTPOCUS, HOTPOCUS. So let's begin. We're going to learn about scanning the IVC and why is this required? The first thing, of course, we need to know it because we use it for AAA and for echo and life support, and possibly we are going to use it to determine shock. If you go on to learn level 2 scans, this is very important to know about. Which probe are we going to use? We're going to use the curvilinear probe, the same probe you use for AAA, or the phased array probe that you use in echo and life support. This is a low frequency probe. Both are low frequency probes. Just pick the one that you like. And then where are you going to place your probe? You're going to place the probe at the epigastrium. What settings to have on the machine? Well, it's nothing special really. Use the settings that you use for fast scan or ELS. Have a good depth before you start to scan, about 15-20 centimeters, and then reduce your depth once you have visualized the IVC. We're just going to practice a little bit because I think these things are a little bit important when you're trying to get good images of the IVC. So if you can get something rectangular and hold it in your hand, maybe a spectacle case or a post-it pad or a diary that you've got nearby, and then try and place it with its side on a flat surface or your palm. All right, if you're ready, we'll begin. So the first movement that you have to do is rotating the probe, and this occurs between your fingers. So you're going to rotate the probe between your fingers. You can do it clockwise or anti-clockwise. The probe remains at the same location, but the direction of the probe marker is changing. You can do it clockwise as well. So try doing that between your fingers. Then you're going to try another movement of the probe called tilting. And here the movement is occurring at your wrist. So you're going to extend and flex your wrist so that you're tilting the probe on the patient's body. So the probe remains on the same location and the pointer direction is also the same. Right, the next movement is called fanning. So you're going to move your forearm here and you're going to do supination, pronation type movements, much like you're holding a handheld fan. And imagine that the waves that are coming out of the probe are spreading like the fan you're holding in your hand. So the location of the probe remains the same. You're just fanning the end of the probe. So location is the same and direction also remains the same. Then you're going to do a movement called sliding. So here the movement, your body movement occurs at the shoulder. So move the entire probe up or down, left or right. So if I come to you and I'm teaching you on the shop floor and I say slide the probe, this is what you will do. You will move the probe up or down. The location changes, but the direction doesn't. All right, so now you've learned some of the basic movements. How to get a good view of the IVC depends on using all of these movements. Okay, so step one is you're going to put the probe longitudinally just under the xiphisternum. So you can put your spectacle case or the post-it pad you have in your hand longitudinally right up in the xiphisternum. Move it all the way up so that you feel the bone of the sternum. Then you're going to tilt the probe as if to look into the chest. Okay, and you're going to find the beating heart. Then you're going to do a combination of fanning, rotating, and sliding towards the patient's liver, that is the patient's right side, to see the IVC entering the right atrium, passing through the liver. Now, how this happens is place the probe, move it up, tilt it down, and then slide, rotate, and fan to then end up in this particular position on the patient. Okay. So what does that look like? So I've put the probe down, I've tilted here to find the heart, and then I've rotated, I've done some sliding and fanning to find the IVC entering the heart. The IVC, you have to show for exam purposes, opening up into the right atrium and passing through the liver. This is an important part of your OSCE triggered assessment. You also need to see that the IVC changes with respiration. The aorta is different from the IVC. Its anteriorly exiting celiac and SMA are the differentiating factors, and that's what you need to show. It also will look pulsatile and thick-walled in the long axis compared to the IVC. So observe the anatomy of the IVC and the aorta. Now, if you want to be good at POCUS, I've always said that if you want to be good at POCUS, you have to be good at anatomy. So observe the anatomy here. The IVC tends to go straight up into the right atrium, whereas the aorta tends to dip below and then goes behind the heart to enter from above. So when you're doing your IVC and your aorta scans, this is what it will look like. So this is the IVC here, and I'm going to fan towards the aorta. Watch where the IVC is and watch how the aorta is. So the aorta is dipping down below the heart, whereas the IVC goes straight up into the heart above the aorta. All right. Also, you must remember that when you're doing any kind of measurements, you'll have to put the probe in the middle of the vessel. If you have your probe cutting the vessel at wrong points, that is not in its diameter, then you're going to make wrong measurements. In the transverse view, the IVC will appear on the left of midline compared to the aorta, which is on the right. IVC can be oval or teardrop, and aorta is round. Aorta will be the one that looks pulsatile, but sometimes the IVC can pulsate and these are transmitted from the aorta, of course. It has no pulsations of its own. And sometimes it may appear non-pulsatile, and the walls are thick and in the aorta. They are thick of the aorta and thin of the IVC. So compare the IVC and the aorta in its transverse section here. You can see the aorta bifurcating, and I'll try that again. So aorta is on the right side of the screen and IVC is on the left. Watch, this one is a oval and sometimes teardrop in appearance. So how to communicate our findings? There are power notes on the EPR. If you go to pre-configured power notes and type in POCUS, P-O-C-U-S, you will get power notes on AAA and echo and life support, and that's where you're going to enter your findings on EPR. All right, so now we can move on to why we need to know about the IVC. We have with us Dr. Conrad Groenewald, and he's an emergency physician. He did his master's on airborne infectious diseases. So he's been fist bumping, he says, from 2016. He loves POCUS, and he's a member of the current reigning champions of the Son Awards competition that was held at the Cape Town International Conference of Emergency Medicine. So let's find out from Conrad why we need to know about the IVC and what do we do with it. Thanks, Conrad.
Thanks for that introduction. Okay, so thanks for that introduction. So what I'm going to talk about is, after you get those views, if you can get those beautiful views, why do we do them, and how do we interpret them? And are we good at it? Are we bad at it? And when are we really not sure? And so just a background, like I said, my previous places where I worked was Cape Town, and I was a consultant in Kimberley, and we had that cool sign. So why do we ultrasound the IVC? Because it sounds great, right? It sounds like we've got a big vessel, it's directly connected to the right heart, it is in the right atrium. It should show fluid status, as we were taught what fluid status would be. And then it's got no valves, like the superior vena cava might have some valves, and the internal jugular has valves. So basically there's no obstruction to flow. So it sounds like the answer. That's why people have been looking at it for ages, and we need to know what fluid balance is and what fluid status is and what people respond to fluids. Because yes, it's too little fluid's bad, but we also know now that too much fluid is bad. And also it's kind of nice to see where we are, not just guessing, not just putting an NIBP on repeat. If you don't have an A-line, see the response. You can see it and you can believe it, and it seems like it should be the answer, and it will be great. So the surface anatomy of the IVC, like I said, it starts at they're in the belly. It's a long, big, thick, or not thick, but long and big, and it's the biggest vein in the body. There we go. Superficially, that's where you're going to find it, like Priya showed, why we put the probe there, because that's the surface anatomy, and that's where you're going to go look for it. And that's the interaction we're looking for, the IVC going into the right atrium and then giving us feedback directly to the heart. So it sounds like the answer. It sounds like one of the coolest things that came since bread came sliced. But you can already think that because something is too good to be so good, is it too good to be true? And what assumptions do we make when we look at it? So the first time that someone published on the IVC, would be an index for the right sides of pressure, were cardiologists while they were doing echoes in the 80s, and that's about 36 years ago. They looked at it and said, well, we can look at the IVC, and then the IVC would then reflect the return pressure or the pushback pressure from the heart. And then people were like, okay, that's cool and all, was relatively quiet. And then since the Armenian and the Turkish earthquakes in 1988 and 1989, I think, so then people said, wait, they used point of care ultrasound, and I think that's where point of care ultrasound actually started. They used it as mass triage, mass casualty triage. They did ultrasounds for fasts and lungs, not lungs yet, but fasts instead, because they couldn't CT everyone after the earthquake disaster. And people started thinking, wait, can we use this tool? Can we teach people this tool, and can we get better at it? So then the dialysis people, the nephrologists jumped in and said, okay, we are going to do hemodialysis. And while we do hemodialysis intermittent, we're taking a lot of fluid off, we're using dry weight, can we not look at the IVC and changes in IVC? So they actually were quite positive and said, well, we will look at the IVC and the change in IVC during dialysis to look at effectiveness. And then since the paper in 2004 where someone said, listen, we're going to look at the respiratory changes to the IVC in septic patients, and does it correlate with our fluid management and our style? And then everyone went, okay, this is it. For all the good reasons, this is where we are. And it became mantra, and everyone was taught IVC. And there was a stage in medicine where if a patient is dry or giving fluids, people would ask, did you measure the IVC? And then as any good test in medicine goes along, we realize that, oof, you know, are we overcalling it? Are we overconfident? What are we right? Are we right even? Are we doing good for the patient? And at the moment, the last few years, people are saying, well, maybe it's not so good. Maybe we are overthinking this thing, and maybe it has these opportunities to be great, but it might just not be what we are. And because of those opportunities, the next step is probably going to look at, if it's not great for one thing, could it be great for another? But let's talk about what we use ultrasound for. So many things, and I not looked at filter, or if you do IVC filters and placements and stuff. So in terms of emergency medicine and critical care, the three big things we look for is the fluid status, the fluid responsiveness, and the diagnosis. And when you look at the fluid status, like we said, it's there, it's right into the right atrium. So by our thought process, if you look at the venous capacitance, we should be able to see if it's big, you're full, and if it's small, you're empty. So because it is a marker of your CVP, your central venous pressure. And that's been some of the first things that came out. There were numbers saying this is a marker. When your IVC is this big, 1.7 or whatever, there's different tables, then it means you try. If it's bigger than that, then you're normal, and then if it's bigger than that, so okay, people were doing IVC all around. Then for the last at least 5-6 years, it's been a plethora of data saying the CVP is absolutely bad for looking at fluid status, because it's an interaction between the vessels and the heart. So what if you are normovolemic, but you got endogenous catecholamines going, and your heart's just managing? What if your heart is just strong at that moment and it looks empty because everything that's going to it is working? Do you not give fluid? What if you are fluid behind, you got acute cor pulmonale, you got septic cardiomyopathy, and your heart's not doing well? So all that it means is push back, and it doesn't mean anything about the fluid status. So it's been scrapped from almost any guideline that the CVP should be used as a marker of fluid status. And if the IVC is a surrogate of the CVP, then they both are not good markers for fluid status. And static markers of fluid status like IVC and CVP are not good markers for fluid status. This is the table I was speaking about earlier. IVC, if it's smaller than 1.7, then that's your right atrial pressure in terms of your CVP. But its CVP has been off so long that that's not even a case anymore. So is it a good marker of fluid status? The answer is no. And because of that, in the journal Ultrasound Medicine, which shouldn't have been one anyway, so in January 2020, people were thinking, if there is bad evidence for showing your fluid status, then, and it shows the right atrial pressure, what if we use it for showing who's in heart failure? And I think the next, where we are on fluid status, then this study that was done in like Jan 2020 said, well, if the IVC is big, we were probably looking at people with bad hearts for the acute dyspnea and not just fluid status. And that might be where we are going in the future for fluid status. What's the second question we got? We are giving fluid, or should we give fluid? We really need to know for the pros and cons of fluid balance and critical ill management. So what is fluid responsiveness? And there you get, that's the standard current definition of what is fluid responsiveness. That is defined by Paul Marrick, and it was arbitrary, but it's kind of got mainstream effects. He just, I think he thumbsucked it. It didn't need a lot of papers to prove it, but now it's the quoted current definition of positive fluid responsiveness. And the NICE guidelines actually added the crystal load you're using, try it with a sodium content of 130 to 154, which would be anything from plasma light to normal saline. So when we check fluid responsiveness, we can use concepts of static checks, dynamic checks, and volumetric checks. Static checks are out, and I'll go through that. It's been disproven. Now the dynamic checks, and that's where ultrasound comes in that fall. It is part of the dynamic check. So you can look at fluid responsiveness by ultrasounding variations and respiratory variations, and that should indicate, hopefully, if you can get fluid or you will be good at getting fluid. And that, I'm not going to go too much about the Frank-Starling curve. This is ingrained in probably everyone's minds from uni, but it does show that people who are fluid responsive, if you use the IVC to look at fluid responsiveness, and anyone who's fluid responsiveness, it doesn't mean they need fluid. You and I can sit there relatively okay, get a fluid bolus, and the normal heart should increase cardiac output from a fluid bolus. So it doesn't say that if you have fluid responsiveness that you actually need fluid or you're fluid behind. But it does say if you're not likely to be fluid responsive, we shouldn't give it to you. That's probably what we're looking for. And we also increase in central venous pressure. We cannot use static markers. They are out in some of the articles you read. They actually ask you, please stop using static markers such as CVP and single check ultrasound of the IVC for using fluid responsiveness. Now, the next step would be, where does IVC ultrasound fit in looking if a patient's fluid responsive? And it's over there by, you can look at the IVC diameter variations, but it's also got caveats, and people have also actually looked at the superior vena cava. But let's talk about the IVC variations and what we can use. So in critically ill patients, you got the people who are unintubated and the people who are intubated. And the unintubated patients, the respiratory dynamics completely different to the intubated patient, negative pressure and positive pressure. So what's the change if you inhale in a spontaneously breathing patient versus exhale? And the opposite happens when you are mechanically ventilated. So people said, wait, we can't just look at the IVC at once. We have to make an index, because we're looking for change. We're not looking for static. We have to make an index, and we'll do a collapsibility index. We'll call it collapsibility because when you breathe spontaneously, you have negative pressure. And we'll call it a distensibility index if you breathe, if a machine is pushing air into you, because the variation in the IVC will be different. And they're still not the best validated studies, but then there's a little formula you do, what's the biggest the IVC was and what's the smallest it is. So when you're breathing in, the out minus in, you don't have to remember that formula. Don't worry about that. But why people are looking at it, because the pros of ultrasound stay the pros of ultrasound. If you got it, it's bedside, it's non-invasive, there's no radiation, it's repeatable. If you got the expertise, all those pros are there. And some of the other methods that people look are not there, because if you have a dysrhythmia in a mechanical or non-mechanical ventilated patient, almost all the other tests are not possible and they are defunct. While changes in variation in IVC can happen in sinus rhythm, atrial fibrillation, any dysrhythmia that you currently have, because they talk about the heart-lung interaction. The study where I got that picture from, I just wanted to show that the current studies that are coming out, you need to read the data for yourself, because if you read the conclusions only, like the study that gave the picture, they said if you ultrasound a patient pre-surgery in elective cases, you can predict hypotension because of the cardio IVC interface. But if you look at go into that, you can just look at that exclusion criteria. Anyone with a little bit of shortness of breath, a little bit of valvular disease, has got a SOFA score more than 1, then they didn't put the patient in the study. And no patient that we ultrasound in ED or critical care would fall into that category. Because you only look at the ultrasound of the IVC, except I see the one Priya used was on probably such good views because it's on a volunteer, but it's difficult in a sick patient. So just there's the distensibility index, the same concept. It's just that when you're spontaneously breathing versus when you are pushing air into you, there's a difference, and there's no standardization for if you use positive pressure in positive end expiratory pressure either. So is it a good way? And at the moment, and look at the dates there, 2018, 2017, 2019. At the moment, the thought is it's a tool, it's invaluable, it's got poor sensitivity, it's there, we want it to be great, but the negative test cannot rule out fluid responsiveness. You have to take it into context. It is so debatable that one of the big leaders in this field actually said, please stop using it. So when we are doing these things and you're looking at distensibility and collapsibility, it is so difficult to get good views, good data. It doesn't mean much. It could just mean that the heart's bad, that the current thought is maybe we shouldn't do it. Maybe we're asking the wrong questions, and maybe in terms of fluid responsiveness, that's not where we should go looking. There are other indices that people tried because it's such a sexy place to look that people are looking at. What if I look at the IVC and their aorta and make an index for the two? Or what if I do the IVC and the internal jugular and then look at the difference? And that showed no changes either. Couldn't really pick it up. But if you look at that first study that's up there, or the top study, if you have hypervolemic shock class 1, why would you really want to use ultrasound for that? If a patient came in dehydrated, would you not give him fluid? If a patient came in with hemorrhagic changes or he bled, you're not going to run to the IVC to find out if you're going to give him fluid. You're going to give him crystalloid blood products first and then try to figure out what's going on. So other controversies of looking at fluid responsiveness, and Priya poked on this before, if we are looking at an imperfect marker, right, what happens when you have an imperfect view of an imperfect marker? If you don't hit that IVC right in the middle, then you probably shouldn't be measuring it, and you probably shouldn't be taking it into account. And when do you know you're in the middle? Is there a defined nice middle? Are you looking at the walls? And what about the patient position? All the studies that we have, and are they patient lying flat? Are they a patient in 45 degrees? That is not mentioned in the data. And unfortunately, the person we run to do an ultrasound on in ED or critical care is not the healthiest patient. We can't get the best views. He's got so many things going on that it is already difficult just to get that sexy views. So people have talked about image quality and the fact that when people do ultrasound, even experts in between each other, there's different bedside clinician changes. We are not great at our intraocular reliability. We are acceptable, and especially if you take pictures and keep the pictures and have a clinical review afterwards, but real-time evaluation can change from 5 minutes to 10 minutes and different operators. So it's a really difficult thing to say, this is the answer. And there's other barely touched on controversies that I've thought that it was only mentioned in a study I read in 2012, that when we look at the IVC and its interaction with the right atrium, right, no one in any study so far has measured the abdominal pressures. And our ill patients, our patients with spontaneous bacterial peritonitis, obstructions, just belly problems, they have something called intraarterial hypertension. And what of that pressure is transmitted to the IVC, and now we're measuring something that might have external pressure from the disease process. And none of the studies actually have looked at correlated with does the patient not have intra-abdominal hypertension? So there's another controversy, and it's a really difficult thing to go for. What else do we use ultrasound for? So we've just discussed fluid status. Unfortunately, fluid status is not a great marker. Then we discuss, are we going to use the ultrasound to see my fluid, did it work, or should I give fluid? And there's again very big controversy and probably not good enough evidence to suggest it. But then should we use the IVC as part of our diagnosis? And this study that came out in this year basically looked at people clinically evaluating a patient only, and then someone took an ultrasound and only ultrasounded the patient. And what is the result? were we accurate with the final diagnosis upon discharge? Right? And as you can see there, there's a 45 and 47%. So if you take a doctor and he only examines a patient in ED, and all the tricks from ED are there, like it's difficult, it's environment, you don't have all the information. Sometimes the information comes to you 2-3 days down the line. You have to make a decision. In that study, they were 45% accurate, which is still low. But even if they just used ultrasound, they were only 47% accurate. So ultrasound plays a massive role in checking why the patient's hypertensive if you use it in conjunction with your clinical evaluation. And the accuracy when they combine the two increased to 89%, and that's massive. That's a massive difference. And but they did say they didn't just look at one context. They looked at the heart, lungs, IVC, abdomen, and aorta in the one check. And if you use that with your clinical gestalt, then ultrasound is a great addition to your skills and to your clinical skills. So in conclusion, the controversy has been there for a long time. There are even people saying it's a dark art. There are people saying it's difficult and we just shouldn't do it. From about 10 years ago, around a resuscitation, everyone asked, what's the IVC? Have you checked the IVC? We are in a stage where it's probably so de-escalated that we are moving away from it. And there's probably in a stage where we're looking, does it indicate heart failure rather than, and your heart struggling rather than you actually fluid deplete? But it is still a tool, and I would still use it in context. Because when you look at a patient, you don't look at one blood result or just the left lung listening or just the one lung ultrasound. You need a lot of data points to make the picture and to fit the picture in. And if you got a patient that you think is hypotensive from a PE and you do the ultrasound, if that IVC is standing up massive, it fits in with your picture. If it's not, then you're like, ooh, maybe I should rethink what's going on. So you always treat the patient and not the scan. And this I just put in, always integrate POCUS into the clinical context. Because if you think that this test is the alpha and omega, you will probably be wrong. But that is just a doctor plus POCUS equals better versus a doctor alone.